operating room or in the emergency room. So the polytrauma patient usually हमारे ER में present करते हैं. Outside hospital से अक्सर intubate होके stabilize होके आते हैं, but in reality they are far from stability. So the actual treatment hence begins. So I'll present a case scenario. So this was the case when I was working with since few years back. So 25 years old male polytrauma patient is shifted from ER to intensive care unit. After initial resuscitation, multiple rib fractures थे, left ICD insertion और intubation ER में किया गया था. Pedestrian was hit by a speeding car. So on presentation, these were the vitals. Patient was tachycardic, he was hypotensive, and 90% saturation with he was tachypneic with a respiratory rate of about 35 per minute. His GCS was E2, M3 and E2. So because of the poor GCS and poor hemodynamics, the patient was intubated and sedated in the ER. Now, these were the injuries that guy sustained: frontotemporal hematoma, splenic laceration grade 1, left pneumothorax, and there was an open tibial fracture. Okay. So despite the adequate pain relief sedation, patient remained to have tachypnea and was in hypoxic. Oxygen requirement FiO2 उनका बढ़ता चला जा रहा था. Okay. So he was afebrile. There were no petechial rashes.
Whether the patient was unconscious?
No, sir. We have sedated. We have sedated, intubated, and an ICD was put in the ER itself, with the resuscitation being the ER. ICU में जब shift किया, patient को फिर भी tachypnea था, increased oxygen requirements थी, and the blood investigation showed no thrombocytopenia. Now, why was the oxygen requirement increasing? Although the air entry was normal on both the sides. The first thing we suspect, एक polytrauma patient में अगर air entry अगर oxygen requirement बढ़ रहा है तो शायद pneumothorax हुआ होगा या pneumothorax हुआ था. This was not the case. So we ran down. We have ultrasound in the ICU itself. हमने एक lung USG किया. Lung USG पे हमें ऐसी findings मिली थी. So what are these? These are B lines. These are B lines on lung USG. It's a very good thing. अल्ट्रासाउंड अगर हमारे पास ICU में है तो बहुत सारी चीज़ें तुरंत पता चल जाती हैं. तो ये B लाइन्स मिल रही थी. इसमें रूल आउट हो गया पेशेंट को न्यूमोथोरेक्स तो नहीं है, लंग स्लाइडिंग हो गया. सो नाउ व्हाट वाज द नेक्स्ट स्टेप? हमने HRCT कराया. अब सर HRCT में ऐसा कुछ पिक्चर आ रहा है पॉलीट्रॉमा के पेशेंट में. सो व्हाट इज दिस? Any guesses? Anybody from the audience? What are these things in a polytrauma patient with a blunt trauma chest? ना तो ये न्यूमोथोरैक्स है, ना तो ये न्यूमोथोरैक्स है.
Interstitial adjacent.
Very close. Blunt trauma, increased oxygen requirement with a picture like this on HRCT chest. So these are pulmonary contusions. Pulmonary contusions. So now what is the treatment of pulmonary contusion? What do we do if the patient we have has pulmonary contusion? ICD insertion. No. What do? We just sedate the patient. Increase the sedation, and so this was pulmonary contusion. So just increase the sedation, analgesia, and very important thing, if we do an ABG, अगर हमारे patient का FiO2 requirement बढ़ता चला जा रहा है, then we ventilate the patient as if the patient is in ARDS. Simple as that. That's all we need to do. And maintain the hemodynamics. So what could be the other causes? In a trauma patient, if you are getting hypoxia, persistent hypoxia, और वजह क्या हो सकती है जो common है? Tension pneumothorax. Very, very common. You can get a tension pneumothorax. You can get a hemothorax, and yeah, there could be a blunt cardiac injury that is very catastrophic, pericardial effusion, and that can lead to cardiac tamponade. And definitely अगर किसी को multiple rib fractures है तो flail chest हो सकता है. Why identifying flail chest is important? क्योंकि फिर हमें उसको immobilize करना पड़ेगा. You need to call the surgeon, cardiovascular thoracic surgeon, and immobilize that sector. So one very, very important thing in a patient with polytrauma suddenly getting tachypneic, we need to rule out fat embolism syndrome. So that can also present with similar pictures. But what is something very easy to identify some findings. Petechial rashes हो सकते हैं, पेशेंट अगर कॉन्शियस है तो देयर वुड बी, एंड पेशेंट को कोई हेड इंजरी नहीं है तो सडनली ऑल्टर्ड सेंसोरियम हो रहा है, लॉन्ग बोन फ्रैक्चर है, हाइपोक्सिया हो रहा है, kindly suspect fat embolism syndrome. Keep a very high index of suspicion for that. Again, the treatment of fat embolism syndrome, if you can fix the long bone fracture and
Very commonly such type of patients are also associated with fat embolism in brain also.
Yes,
So that
yes.
is also a cause.
It is if the patient is conscious with no head injury, suddenly hypoxia and suddenly altered sensorium, seizures, very high index for fat embolism, and yes, it is very catastrophic. The treatment for this, treat the underlying cause, keep the patient hydrated. So now that thing is dealt with. Now the patient was fine, doing good, but the next day, patient is noticed to have continuous oozing from fractured tibia side. So immediately, जैसे ही हमारे पास patient आता है fractured tibia लेके, with all the other things, we immediately do not fix. We do not go for straight away orthopedic reference, and straight away we do not do open reduction and internal fixation. Now what is happening here? Patient is hemodynamically stable, लेकिन patient को fracture site से continuously bleeding हो रही है, oozing हो रही है, okay? Patient का temperature 35 डिग्री सेंटीग्रेड है, INR भी patient का बढ़ गया है. क्या हो रहा है इस scenario में? What is happening here? Any guesses? Coagulopathy, hypothermia. What is happening here? Huh? Why? 24 hours. What is easier thing to guess here?
Fat embolism with DIC probably.
Yes, sir, DIC हो रहा है. So this is a lethal triad of trauma. So what happens in the lethal triad? So I discuss about the lethal triad: coagulopathy, hypothermia, and acidosis. So trauma causes DIC. Okay, trauma coagulopathy. We'll get back to the pathophysiology. कैसे trauma में coagulopathy होती है? Even though the patient is normal to begin with, but why in polytrauma patient gets coagulopathy? So what would be the next step in this patient? Patient is having coagulopathy, patient is having hypothermia, patient is having oozing, continuous oozing from the fracture site. What will we do? Are we going to straight away go and fix the fracture? Internal fixation? Are we going to do something like that? Or is there a concept of damage control surgery? So there is something known as damage control surgery. What is the meaning of damage control surgery? So what we do, we will take care of the thing that is at present happening. Okay? We will externally fix the wound and irrigate the wound to prevent the bleeding, to prevent any further infection and worsening. So we will not go ahead with definitive repair of the fracture here. We will do the damage control surgery here, that is external fixation and irrigation of the wound. So now coming back to the lethal triad: acidosis, coagulopathy, and hypothermia. This has to be taken care of the trauma patient at all the levels, at the presentation, in the ICU, and during the ICU stay. So almost 30% of the cases, 1/3 of the patients in trauma, they have, at the time of presentation, they present with coagulopathy. So what is happening here? How trauma is causing coagulopathy? So what is happening here is known as consumption coagulopathy or DIC. Patient का इतनी bleeding होती है, there is hemodilution, and there is widespread consumption of के साथ साथ you will give platelets, you will give plasma. So that is to prevent coagulopathy. अगर आप सिर्फ whole blood देंगे, उससे क्या हो जाएगा? You will dilute the coagulation factors. You will cause thrombocytopenia. You will cause coagulopathy. So that is the basic concept behind, and it is very important for the primary care physicians. कि आपके पास कोई trauma का patient आ रहा है, so you will not just order blood. You will order plasma. You will order platelets. So that कि आप उसका blood dilute नहीं करें. If you just give RBC, you will end up diluting the plasma. You will end up diluting the platelets. It will lead to thrombocytopenia and increased iron. So that is the concept behind this. Okay. In this one basic concept, it saves us from a lot of trouble. So now, what is massive blood transfusion protocol? That's what I have said right now. If you want to give blood, give into 1:1:1 ratio. अगर आप एक blood order कर रहे हैं, order for one platelet also and order for one plasma also, so that it will maintain the ratio. Okay, so I talked about damage control surgery. Damage control surgery in trauma patient is कि आप definitive surgery तुरंत नहीं करेंगे. So you will first address the issue that is there in the picture. For example, if there is an open fracture, okay, an open fracture which is infected and which is bleeding. So first we will go ahead for the bleeding control and irrigation of the wound and prevention of infection. Later on, once the patient is stable, then we can go ahead and do the definitive surgery of the patient. So what antibiotic coverage would you prefer in a trauma patient? If there is a patient with closed fracture and there are just few abrasions on the skin, so what antibiotic would you give as compared to a patient that has got a full open fracture and that is contaminated? In general, कोई भी patient trauma का आ रहा है तो क्या हम उसको higher antibiotic देंगे? नहीं देंगे. We'll just begin with basic gram positive. But if you see there is a lot of lacerations in the skin, there are bad open contaminated wound, and there are open fractures, then you can definitely go ahead with gentamicin, anaerobic coverage and gram negative coverage. Otherwise, simple gram positive coverage is fine. So now getting back to our patient in the ICU, after 48 hours, now the patient is not bleeding, hemodynamically stable, oxygen requirement भी normal हो गई है. Suddenly the patient GCS is worsening. So pupils भी उसके unequal हो गए हैं and patient is noticed to have bradycardia and hypertension. A stable patient of trauma suddenly going in bradycardia, hypertension, unequal pupils. So what is the next step? The patient is on mechanical ventilation. What is the next step? What would you do? Any guesses, sir?
CT.
सर CT तो best next. लेकिन उससे पहले अगर हम आप कुछ कर सकते हैं, can we do something?
आपने लिखा है ना पहले hyperventilation
Yes,
scan.
exactly.
बहुत सारे हैं.
Exactly, sir. वरना patient इतना herniate हो जाएगा. और ये हमारी ICU की टीम के लिए last the option, do nothing, call neurosurgeon. ये तो बिल्कुल नहीं करेंगे. That is the knee-jerk reflex, call the physician, call the surgeon, जिसके patient भेजा उसको तुरंत call करें. उससे पहले कुछ करेंगे, that is A. We will hyperventilate the patient, right? Because what is happening, maybe the cerebral edema is happening, and what will hyperventilation do? It will decrease the edema. Hyperventilation causes cerebral vasoconstriction, हमारा edema कम होगा. So that is the first step before sending to CT. Because CT तक भेजते भेजते patient herniate हो जाएगा, and we can lose the patient. The first step is hyperventilation as a temporizing measure. That means as a temporary measure. Okay. So the CT suggested expansion of hematoma with mass effect. The urgent decompressive craniectomy was done, and the patient was shifted back to the ICU. So the cardinal point of management of traumatic brain injury. So you have a patient in your hospital जिसको head injury हुई है. So you intubate the patient, right? And hyperventilation हम सिर्फ और सिर्फ temporary तौर रखना है, so that cerebral perfusion maintain हो, normal temperature रखना है, normal glycemia रखनी है, coagulopathy prevent करनी है. These are the cardinal points. These are done to prevent any secondary brain injuries. So what are the expected complications of the trauma patient in your hospital? These are very high risk for DVT and pulmonary embolism. Why they are high risk for DVT and pulmonary embolism? It's very simple, because they are not moving and possibly they have some coagulopathy. And ARDS उन लोगों के लिए बहुत commonly देखा जाता है जिनको chest पे injury है, rib fractures है, day 2, day 3 पे उनको ARDS हो सकता है, because maybe by day 2, day 3 they have developed pulmonary confusion, maybe during the trauma they have aspirated, suddenly patient is good and after 2 days you see the ABGs are worsening. Transfusion related complications, because more often than not they need multiple blood products. अब multiple blood products coagulopathy हो सकता है, hypocalcemia हो सकता है, acidosis हो सकती है. These things are to be taken in consideration. And these patients are often associated with ventilator associated pneumonia, because when we intubate these patients, it is done in quite a lot of hurry. Sometimes maybe the septic precautions are not taken in the ER. Okay? So one thing was seen in trauma patients, जिनको पहले हम लोग Volumen देते थे. Many of us still we give Volumen. What used to happen, because of a lot of blood loss, these patients were hypovolemic. Often what was the practice before, 5 to 6 years back, we used to give a lot of Volumen. So what has resulted? These patients, they used to get acute kidney injury. So trauma का कोई भी हमारे पास patient आ रहा है, we should avoid using Volumen or Gelusil, Gelufusil. So what we should rather give, normal NSRL, normal balanced salt solution and blood, rather than giving Volumen or Gelufusil, because it results in acute kidney injury. So the take-home message is that trauma kills in a predictable fashion. It is an algorithm. The complications are all well known. This is going to happen. All we need to do is to keep a high level of suspicion. Multidisciplinary approach is required. A team of doctors, and always we should look for all the missed injuries, and definitely look for the lethal triad, that is